So my dad had a heart attack when he was around 40 years old, and at the time, 40 seemed like this really distant number, like really far off, almost abstract. But now it is only a few years older than I am, and that lands very differently than it used to. Because since becoming a doctor, and particularly since spending years working in emergency medicine, and I mean across the full range from really big tertiary centres to major trauma hospitals to really small rural A&E departments where overnight there's literally just 2 doctors covering the whole thing, I keep seeing something that brings that thought right back. Patients arriving with a heart attack who on paper look completely fine. They're not particularly overweight, they exercise a bit, some of them have been told, sometimes only months before, that their cholesterol is normal and everything looks good. And yes, something has clearly been quietly building in the background for a very long time before that moment in the resus bay. And let me just say, we see heart attacks every single day. And I mean that literally. There is no wonder it is the most common cause of death in the world. When something is common, doctors will see it all the time. And when you see it day in, day out across different hospitals, different populations, different parts of the country, you start to notice some patterns. You start to ask some questions. And the really uncomfortable truth about all of this, and this is what this video is really about, is that the standard health checks that most people rely on and that most doctors routinely offer often miss the early warning signs completely. Not because the doctors are bad, but because the standard tests that we do just weren't designed to catch this stuff early enough. So today, what I want to talk about is why heart attacks happen in people who seem healthy. And I want to walk you through some of the markers and the tests that can give a much more accurate picture of what's actually going on inside your arteries, most of which you'll probably have never had done, and most of which your doctor probably hasn't offered you. Before we get into why this happens in people who seem healthy, let's just take a moment to explain what's actually going on during a heart attack, because a lot of people have a vague idea but don't really know the actual mechanics, and it really helps to know this stuff. So your heart is, well, it is just a muscle, and like any muscle, it needs a constant supply of blood and oxygen to keep it working. That blood is delivered through a network of arteries that wrap around the outside of the heart, and we call these the coronary arteries. Now over time, and we'll get into exactly why in a moment, over time, fatty deposits can build up inside the walls of those arteries. This is called plaque, P-L-A-Q-U-E. And for a long time, that plaque can just sit there, stable, causing no symptoms, not blocking enough blood flow to cause any obvious angina or chest pain when you walk. But the thing is, some of that plaque eventually becomes unstable. The outer shell of it becomes thin and fragile, and when that shell ruptures, which can happen suddenly, sometimes triggered by a spike in blood pressure or a surge of adrenaline, physical exertion, something like that, the body treats it like an injury. The clotting system in your body kicks in immediately, trying to seal the rupture, and that clot can grow really rapidly until it blocks the artery completely. And when that happens, the part of the heart muscle that was being supplied by that artery is suddenly cut off from oxygen. It's the same thing that happens in particular strokes as well. And heart muscle cells start to die literally within minutes. And that is a heart attack. And the really important thing to understand is that the plaque that ruptures is not necessarily the biggest plaque. It's not necessarily the one that was causing the most blockage. It's often a smaller, softer, more vulnerable plaque that nobody knew was there, which is exactly why somebody can have a normal stress test, feel completely fine, and still have a heart attack days later. Now, when most people picture somebody at high risk of a heart attack, they picture a certain type of person, maybe overweight, unfit, maybe a smoker, obviously an unhealthy lifestyle. And yes, those risk factors matter enormously. But the reality that I see in clinical practice is a much more complicated one than that. There's a concept that I think more people need to know about, and that is something called TOFI, T-O-F-I, thin on the outside, fat on the inside. Now, these are people who are a perfectly normal weight, who might even look lean, but who are carrying significant amounts of visceral fat, the fat that sits deep inside your abdomen, packed around your organs. And visceral fat is metabolically completely different to the fat that you can just pinch under the skin. It is hormonally active, it drives inflammation, it drives insulin resistance, and it dramatically increases your cardiovascular risk. And the thing is, you'd never really know this just by looking at them. And the next group are these people who look really fit and healthy on the outside, but whose diet is quietly catastrophic. We all know somebody like this who is fairly lean, but has a shocking diet, high in ultra-processed food, refined carbohydrates, added sugar, whose metabolic health is deteriorating under the surface, but they're not quite showing it yet. Or you've got the marathon runner, the person who does incredible amounts of cardiovascular exercise, but who has a family history they've never properly investigated and a CAC score that would genuinely surprise them. And by that I mean coronary artery calcium score. Now, yes, exercise is hugely protective, but it's not a complete shield against underlying disease that has been building for decades. And this is the point of this video. Cardiovascular risk is invisible in a way that most other health problems aren't. You can't see it, you can't feel it until suddenly you can. So the first thing that I really want to get across, and I think this changes everything when you properly understand it, is that a heart attack is almost never sudden. It feels sudden, it looks sudden from the outside, but the biology that leads to it has typically been developing for decades. There's a study that I really want to mention called the PDAY study, PDAY, and it stands for Pathobiological Determinants of Atherosclerosis in Youth, PDAY. And, yes, that is a mouthful, but what it actually did was really interesting. Researchers performed detailed autopsies on young people who had died in accidents, people in their teens, their 20s and 30s who had no known heart disease. And what they found was really striking. Fatty streaks, which are the very earliest signs of plaque building up in the arteries, these were present in teenagers. And just think about that for a second. People who would have described themselves as completely healthy, who had no symptoms, no diagnosis, and yet the process had already started. So the process that eventually leads to a heart attack in your 50s or 60s, it doesn't begin in your 50s or 60s. It often begins silently, decades earlier. And that is really important to understand because it completely reframes how we should be thinking about prevention. So if heart disease develops over decades, and if people having these heart attacks often seem healthy, then what is actually driving it? What are the biological processes running quietly in the background? Well, let's take you through four of the big ones. The first one is atherosclerosis. This is essentially the process of plaque building up in the walls of your arteries. The way I usually explain this to patients is imagine your arteries, well, as just basic pipes. Over time, if the conditions are right, then fatty deposits start to accumulate inside the walls. Not on the inside of the pipe necessarily, but within the wall itself. And the artery wall actually tries to compensate. It remodels around the plaque, so the internal diameter of the artery can stay looking relatively normal for a long time. And that's one of the reasons you can have quite significant disease and have no symptoms whatsoever. And what's really important to understand is that this process is largely driven by modifiable risk factors. There was a landmark study in The Lancet in 2004 called the INTERHEART study. It looked at over 29,000 people across 52 countries, and it identified 9 modifiable risk factors that between them explained over 90% of heart attack risk globally. 9 factors, and I did a video on this a few days ago, and it includes things like cholesterol, smoking, diabetes, high blood pressure, abdominal obesity, and also psychosocial stress. The point being that this is not a random thing. Heart disease is largely predictable. It follows biological rules, and that means it's largely preventable, but you have to catch it early and you have to be measuring the right things. The second driver is insulin resistance, and this is probably the most underappreciated thing in cardiovascular medicine right now. So I really want to spend a bit of time on it. So insulin is the hormone that your pancreas releases to manage your blood sugar. When everything is working really well, your cells respond really nicely to insulin. Your blood sugar stays in a healthy range and life is good. But when cells start to become less sensitive to insulin, which can happen for lots of different reasons, including your diet, inactivity, poor sleep, chronic stress, the pancreas has to produce more and more insulin just to keep your blood sugar normal. At this stage, where insulin is elevated but your blood sugar still looks fine, we call this insulin resistance. And here's why this matters so much for your heart. There was a study called the Quebec cardiovascular study that followed men over time, and it found that those with the highest fasting insulin had roughly 5 times the risk of developing heart disease compared to those with the lowest levels. 5 times, even when their cholesterol was completely normal. And the really important thing about insulin resistance is the timing. Your blood sugar can look completely normal. Your HbA1c can come back in the healthy range. Your fasting glucose can be fine, and yet your insulin can already be elevated. Your arteries already under stress, and the process can already be underway. Standard blood tests won't pick this up unless someone specifically measures insulin. The third one is chronic inflammation. Now, your immune system is incredible at protecting you from short-term threats. But when it's in a constant low-level state of activation, which can happen because of, again, poor diet, visceral fat, poor sleep, chronic stress, that persistent inflammation is damaging to your blood vessels. It's actually one of the key things that converts stable plaque into the kind of unstable plaque that's much more likely to rupture and cause a heart attack. The evidence for this is, again, really powerful. So the CANTOS trial enrolled over 10,000 patients who had already had a heart attack, and it tested whether lowering inflammation without changing cholesterol at all would reduce their risk of future heart attacks. And it did. There was a 15% reduction, 1.5, in major cardiovascular events. And the patients who responded best, a 31% reduction in cardiovascular mortality, meaning death. And that is an enormous effect. And what it tells us really is that cholesterol and inflammation are separate risk pathways. You can address one and still have the other quietly driving disease in the background. And the fourth driver is genetics. And as I mentioned at the beginning, this one is personal to me. So bear with me for a second. When I first started medical school, I became properly aware of what heart attacks were. The mechanisms, the biology, the risk factors, and it made me think about my dad. So I actually took the initiative to go to my GP and say, look, my dad had a heart attack when he was quite young, and I think I should probably get some checks done. And I remember sitting there thinking that I'm being really proactive. Clearly back then, and this was maybe, say 15 or 16 years ago, I thought my doctor was going to be screening for anything genetic that might be relevant. But from what I can remember, all they did was check my cholesterol, and that was it. One number, and it came back fine, obviously. And that was the end of the conversation. Now, let me just be really clear. This is not a criticism of GPs. GPs are working under enormous pressure with limited time and limited resources. I used to work in general practice for a few months, and they are doing an incredible job. But what that particular experience shows is that there is so much more to cardiovascular risk than a single cholesterol number. And most people, including younger me, including a medical student, don't know that. They trust that if cholesterol is fine, then they are fine. And specifically, I want to talk about something called lipoprotein A, which is a particle that carries cholesterol in the blood, but it is genetically determined. You inherit your lipoprotein A level from your parents, and there is very little lifestyle can do to change it. Around 20% of the population has elevated lipoprotein A, and elevated lipoprotein A can roughly double or even triple your cardiovascular risk. The European Society of Cardiology recommends measuring it at least once in every adult. But in routine practice, most people have never had it tested. We don't routinely do this in the NHS. If you have a family history of early heart disease and you've never had your lipoprotein A measured, then that is a big gap worth addressing. At this point, I want to come back to something that I mentioned earlier when we were talking about the INTERHEART study, which is psychosocial stress, because it was one of the 9 risk factors identified in that study. And I think it's probably the one that gets dismissed the most. So people hear the word stress and think, well, everybody's stressed, that's just life. But the biology of what chronic stress does to the cardiovascular system is significant, and I don't think enough people really understand it. So when you're under chronic stress, whether that's work-related, relationship-related, to do with your finances, your body produces elevated levels of cortisol, your main stress hormone. And cortisol over time does several things that are really damaging to your heart. It raises your blood pressure, it raises your blood sugar, it promotes the accumulation of visceral fat, particularly around the abdomen, and it drives insulin resistance. So chronic stress isn't just bad for your mental health, it is actively accelerating the biological processes that lead to heart disease. There's also a direct effect on the heart itself. Chronic stress increases the tendency of blood to clot, and it promotes inflammation in the artery walls. And then we've got the behavioral effect on top of that. So people who are chronically stressed tend to sleep worse, they tend to exercise less, they tend to eat more ultra-processed food and drink more alcohol. So you've got a direct biological pathway and then a whole set of indirect pathways layered on top of that. Now, the evidence linking work-related stress and social isolation and depression and anxiety to cardiovascular outcomes is enormous. This is real biology with real consequences. And the reason I think it matters to include it in this video is that for a lot of people watching, their cholesterol is fine, their blood pressure is borderline or normal, and yet they're under relentless chronic stress that is quietly and steadily damaging their cardiovascular system in ways that won't show up on a standard blood test. At this point, it's probably worth talking about diet for a bit, but not in the way that diet usually gets talked about in these kinds of videos, which is often just, eat less saturated fat and watch your cholesterol. Because the evidence has moved on significantly from that point, and I think there's a much more important and much more nuanced story to tell. So the thing that I think has the biggest impact on cardiovascular health from a dietary perspective, and this is increasingly backed by solid research, is ultra-processed food. Ultra-processed foods are products that have been industrially manufactured, often with large amounts of added sugar, refined carbohydrates, artificial flavorings, emulsifiers, preservatives. They've had billions of dollars spent on them to be as easy to eat as possible, to get you to eat more and then buy more. Ultimately, it's all about sales. And there are loads of studies out there linking high consumption of ultra-processed food to cardiovascular risk. A large prospective study published in the BMJ followed over 100,000 people and found that a 10% increase in ultra-processed food consumption was associated with a significant increase in cardiovascular disease risk. And the mechanism here isn't just about fat or even just about calories. Ultra-processed foods drive insulin resistance. They promote chronic inflammation. They displace the whole foods like veg and legumes and fruits and nuts and seeds and olive oil that actively protect the cardiovascular system. They displace them out of your diet. There's also the specific role of added sugar and refined carbs, which spike your blood glucose and insulin repeatedly throughout the day. And over years, it contributes directly to insulin resistance and elevated triglycerides and visceral fat accumulation. The PURE study, which is the prospective urban rural epidemiology study, which followed over 135,000 people across 18 countries, found that high carbohydrate intake was associated with higher cardiovascular mortality, while higher fat intake was actually associated with lower risk. And that completely inverts the dietary advice that most people grew up with. Now, I'm not saying that fat is irrelevant, far from it. The type and quality of fat matters. But the obsession with dietary fat as the primary driver of heart disease has honestly distracted us from the more important story, which is that the metabolic damage caused by a diet built around refined carbohydrates and added sugar and ultra-processed foods. Okay, let's talk about blood pressure. So blood pressure is probably the most powerful independent risk factor for cardiovascular disease. And yet most people only have a very vague understanding of what it actually means and what it actually does, or indeed what their number actually is. So let me try and explain it properly. So your blood pressure is the force that your blood exerts against the walls of your arteries as your heart pumps around the body. And it's given as two numbers, systolic over diastolic. The systolic number is the pressure when the heart beats and pumps blood out away from the heart. The diastolic number at the bottom is when the heart is resting between beats. Now, a reading of around 120/80 is generally considered healthy, but here's what most people don't realise. The damage that high blood pressure causes happens silently over years with absolutely no symptoms. High blood pressure damages the inner lining of your artery walls, and damaged artery walls are exactly where plaque likes to form. So elevated pressure and atherosclerosis feed each other in a way that dramatically accelerates the disease process. The evidence on how serious this is comes from enormous population studies. Your risk of cardiovascular disease doubles with every 20-point increase in systolic pressure above 115. Now that's not starting from what we'd call high blood pressure, that's starting from 115 systolic, which is well below what most people would even be told to worry about. And one of the most important things to understand about blood pressure is the white coat effect. The fact that a single reading at the GP surgery, taken when somebody might be anxious or rushed, is often not representative of what their pressure is actually doing the rest of the time. Home blood pressure monitoring over several days gives a much more accurate picture. So if you don't own a blood pressure cuff, then honestly consider getting one. You can get one for about 15, 20 quid off Amazon, maybe 30, 40 quid from your pharmacy. You know, they are cheap, they're easy to use, and the information they give you is some of the most powerful health information that you can have access to. Can I just say quickly that I really hope you're learning something from this video today. This one has been a particularly interesting one for me to research and produce, and it touches on stuff that's really personal to me as well as clinical. So if you're getting value from it, then please show your support by liking the video and subscribing. Let's try to get this out to as many people as possible and prevent as many heart attacks as we can. Okay, so we've talked about the drivers of heart attacks. Now I want to get into the more practical stuff, because this is the part that I think is most useful. If you want a clearer picture of your actual cardiovascular risk beyond what a standard cholesterol panel gives you, then these are the markers worth knowing about. The first one is what we call ApoB, apolipoprotein B. And yes, it sounds very technical, but the concept is actually quite simple. When we measure standard cholesterol, we're measuring the cholesterol content inside various particles in the blood. But what actually causes the damage is the particles themselves, specifically the ones that can burrow into the artery wall. And ApoB is a protein that sits on every single one of those damaging particles. One ApoB protein per particle. So measuring ApoB gives you an actual count of how many of those harmful particles are floating around in your blood, which is something that LDL cholesterol doesn't tell you. And there's really good evidence that ApoB predicts cardiovascular risk better than LDL in many situations. Studies and meta-analyses suggest that for roughly every 10 milligrams per deciliter increase in ApoB, your cardiovascular risk goes up by around 20%. Now, it's not universally available on the NHS, but it is something that you can ask for or have done privately, and it's a much more informative measure than standard LDL. The second test is lipoprotein A. Now, as I mentioned earlier, this one is genetic. It needs measuring just once in your life. If it's high, you and your doctor need to know that, because it significantly changes how aggressively other risk factors should be managed as well. Test number 3 is insulin. So fasting insulin is the test that would pick up the insulin resistance story that I was telling you about earlier. A fasting insulin level, ideally alongside a fasting glucose, lets us calculate something called HOMA-IR or HOMA, depending on where you are, which is a measure of insulin resistance. You can have a normal HbA1c, a normal fasting glucose, and yet a fasting insulin that reveals your pancreas is working much harder than it should be to keep everything looking normal. This test is not standard. You will almost certainly have to ask for it specifically and pay for it. But if you're trying to get an honest picture of your metabolic health, then it is really useful. Test number 4 is your triglyceride to HDL ratios. Now this one is really interesting because it uses numbers that are already on a standard cholesterol panel. So if you've had a cholesterol test recently, then you probably already have what you need to know to calculate this. You just divide your triglyceride level by your HDL level. A ratio below 1 is good news. Above 2 is where things start to look concerning, and studies show that this simple ratio is actually a pretty strong predictor of both insulin resistance and cardiovascular risk, yet most people have never been told about it. Test number 5 is high sensitivity CRP. So CRP stands for C-reactive protein, and it's a marker of inflammation in the body. High sensitivity CRP is a much more precise version of this test that can detect lower levels of chronic inflammation. Now, the numbers to know are roughly under 1 milligram per litre is really low risk. Between 1 and 3 is moderate, and above 3 is elevated cardiovascular risk. Multiple large prospective studies support its use as a cardiovascular risk marker. And this is actually one that is more routinely available. The issue is it's just not always ordered as part of a standard cardiovascular screen. And even when it is, the results often aren't explained in any real context. Okay, test number 6 is coronary artery calcium scoring, CAC score. And this one is different to all of the others because it is not a blood test. It is a CT scan, specifically a low-dose CT scan of the chest that looks for calcium deposits inside the coronary arteries. And the reason calcium matters is that it accumulates inside arterial plaques. So a CAC score is essentially a direct measurement of how much plaque you already have built up in your arteries that supply your heart, if that makes sense. A score of 0 is no calcium detected. This is really reassuring. Now, there was a major study called the MESA study, the multi-ethnic study of atherosclerosis, which followed thousands and thousands of people over years and found that those with a CAC score of 0 had an extremely low risk of a heart attack over the following decade. Meanwhile, higher scores were strongly predictive of future cardiovascular events. What makes this test so powerful, though, is that it's telling you about the actual state of your arteries right now. Not a proxy marker, not an estimate, but direct evidence. A person can have a normal cholesterol, normal blood pressure, no obvious risk factors, and yet have a significant calcium score that shows significant disease has already developed. CAC scoring is one of the most powerful predictors of future heart attack risk that we have. Now, it's not available on the NHS for asymptomatic patients, but it is available privately if you want to pay for it, and the cost has come down considerably over recent years. And there's one more that's really worth mentioning at this point, which is remnant cholesterol. Now, this refers to the cholesterol carried in certain triglyceride-rich particles. Elevated remnant cholesterol is increasingly recognized as an independent cardiovascular risk factor, and you can calculate it from a standard lipid profile. It's just not something people are usually told about. So we've been through the drivers, we've been through the tests, and I want to finish the clinical section with something really practical for you, because I know that a lot of people watching this will be thinking, okay, well, how do I actually get any of this done? Because walking into a GP appointment and asking for 7 tests that you've seen in a YouTube video isn't necessarily going to go smoothly. I completely get that, especially because a lot of these tests are a bit funky. So here's how I'd think about framing this. The first thing is know your reason. If you have a family history of early heart disease, like I do, then say that clearly. This is a legitimate clinical reason to request additional cardiovascular screening, and it changes the conversation. If your parent or sibling had a heart attack before the age of, say, 50 or 60, then that is relevant, and your doctor needs to know if they don't already. The second one is be specific. Don't just say you want more tests. Ask specifically about ApoB. Ask specifically about lipoprotein A. Ask whether fasting insulin is something that they can request. Some of these will be available depending on where you are in the world, but on the NHS, a lot of them won't be. And I say this because we've got people watching from all corners of the world on this channel. So basically what I'm trying to say is that you may need to pay for some of these privately. And that's okay to ask about too, because they could lead you to reputable clinics or, services they recommend. The third one is to ask about blood pressure monitoring at home. Ask whether home monitoring is something that they'd recommend. Ask for guidance on what the numbers should look like for you. And the fourth one is that if you're told everything is fine based on a standard cholesterol panel, then it is completely reasonable to say, I understand, but I'd like to understand my risk a bit more fully. Could we discuss what other markers might be relevant given my history? This isn't you being difficult, you are being an informed patient, and this is what we want. And the reality is that a doctor who is up to date with all of the evidence will understand exactly why you're asking that. And if a coronary artery calcium score is something that you want to explore and is not available to you on the NHS or in your healthcare system, then it's worth considering paying privately for this one because it's only a few £100 and it can give you life-changing information. So let's put all of this back together then. This is probably the longest video I've done in a long time. Why do healthy people have heart attacks? Because the word healthy is often based on incomplete information. It's based on how somebody looks, maybe a standard cholesterol level, maybe a blood pressure reading, but none of that tells you about the state of the artery walls. It doesn't tell you about insulin resistance that's been building for years. It doesn't tell you about chronic low-grade inflammation. It doesn't tell you about a genetic lipoprotein A level that's been quietly elevating your risk since birth. It doesn't tell you about the chronic stress that's been driving cortisol and visceral fat accumulation for a decade. It doesn't tell you about your blood pressure that's been quietly sitting at 135 and quietly, very minimally damaging your artery walls every single day. Cardiovascular disease is usually not a sudden event. It is the end result of biological processes that have been quietly progressing, often for decades, before that moment of crisis. And the really sad thing is that many of those processes are detectable, correctable, and sometimes completely reversible if caught early enough. But this healthcare system doesn't really focus on that sort of thing. We are fantastic at treating a heart attack when it happens. We can get you into the cath lab with a stent into your artery to open up that coronary artery around your heart, but we are terrible at preventing that heart attack from happening in the first place. And look, this video isn't supposed to be scary, it's supposed to be useful. Because the flip side of understanding that heart disease builds slowly over decades is that the window for prevention is enormous. The things that actually move the needle over time are not complicated. Reducing visceral fat, which is the fat around your organs and what contributes to a bigger waistline, is probably the most useful thing that you can do for your metabolic health. Regular exercise, including both cardiovascular exercise and resistance training, is essential. Good quality sleep as well, because sleep deprivation is really damaging to your metabolic and cardiovascular health in ways that are unprecedented. A diet built around whole foods with plenty of vegetables and legumes and good fats, and as little ultra-processed foods as you can realistically manage, is another huge step here. Managing your blood pressure, monitoring it at home, and knowing your numbers and taking it seriously, even if you're told it's slightly elevated, is another huge thing that you can do. Managing your stress, not just as a well-being issue, but as a genuine cardiovascular intervention. And another one is obviously not smoking. It's so obvious it almost feels redundant to say, except that it still accounts for an enormous proportion of preventable cardiovascular deaths. The goal isn't just to avoid a heart attack in the next 10 years. The goal is to prevent the disease process from ever getting properly established in the first place. And to do that, you need to understand what's actually happening in your body. Not just the surface level numbers that you get handed after a 5-minute checkup. Those tests and those sorts of measurements are the bare minimum. And if there's one thing that I want you to take away from this video, it's this. And this is just another repeat of what I've said many times. Don't assume that because you've been told your cholesterol is fine, that your heart is fine. Ask about ApoB. Ask about lipoprotein A. Ask about fasting insulin. You may have to pay for these, but it will be worth it. If you have risk factors or a family history, then ask about a CAC score. Monitor your blood pressure at home. Take your stress seriously. And think really hard about what you're eating every day. Not just the obvious things, but the cumulative effect of a diet that might be driving insulin resistance and inflammation that no blood test is currently measuring. Everything I've mentioned in this video today is supported by robust evidence, and I'll put some links in the description below if you want to read a bit more about these sorts of things. If you stayed until the end, then thank you so much. Please consider liking the video if it's been valuable to you. And I'll see you in the next one.